Dr. Anil, you may start.
Okay, thank you. So, on behalf of AstraZeneca India, I, Dr. Anil Kukreja, extend our sincere thanks and gratitude to Integrated Academic Society of Clinical Oncology for providing us platform and an opportunity to collaborate for non-promotional scientific meeting, and also for facilitating experts and audience to connect together. So on behalf of the Integrated Academic Society and AstraZeneca India, we extend a very warm welcome to all the respected experts and oncologists. At AstraZeneca, we have a bold ambition to bring more than 15 new products by 2030, and we are continuously working towards pushing boundaries of science to bring life-changing medicines to transform the patient's outcome. Especially in oncology, we aim to revolutionize the cancer care with focus on areas of high unmet needs, especially in lung cancer, breast cancer, and the GI cancers. To come to the topic of the day, breast cancer, of course, is the most common cancer, and there are significant advances that have potential to revolutionize the breast cancer care. And we are fortunate to have with us our Global Oncology Medical Affairs colleague, Dr. Sunil Verma, who's pioneering science and leading all our efforts at a global level. He is with us for the initial 1 hour of the meeting. And to welcome Dr. Sunil Verma and also to chair the scientific meeting, I take this opportunity to invite Dr. Ajay Bapna. Dr. Ajay Bapna, as we know, is a senior consultant and head of the Department of Medical Oncology at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. He has more than 23 years of experience. He has been exceptional, known for clinical skills, and he has earned a reputation of being a leading expert in the field of medical oncology. As a dedicated academician, he has contributed significantly to the medical community with more than 36 publications reflecting his commitment to advancing knowledge and research in oncology. So with that brief introduction, I'll hand it over to Dr. Ajay Bapna. So Dr. Ajay Bapna, over to you to welcome Dr. Sunil as well as to conduct the proceedings for the meeting. Thank you so much.
Yeah, thank you, Dr. Anil, for the nice introduction. At the outset, my sincere thanks to AstraZeneca for organizing this meeting. And today's theme of discussion is ADCs in breast cancer, bridging global vision with Indian experience. And none other than our guest speaker today, which I'll be introducing shortly. Can we have the slide, please? Dr. Sunil Verma. He's the SVP Global Head of AstraZeneca Oncology Medical, and he'll be speaking on the today's topic and will enlighten us. He's the Global Head of Medical Oncology at AstraZeneca and is a distinguished leader in redefining cancer care through evidence generation and scientific partnerships. Dr. Sunil Verma has been formerly led the global research and development in breast cancer, making a significant impact on the field. He holds a medical degree, completed postgraduate training at the University of Alberta, and earned a master's in medical education from University of South California, including a breast cancer fellowship at the University of Toronto. With more than 15 years of experience as a medical oncologist specializing in breast and lung cancer, Dr. Sunil served as the principal investigator for pivotal breast cancer trial, contributing to over 125 peer-reviewed manuscripts. Recognized among top 25 young best oncologists in the world in year 2006, received the Future Forum Award, acknowledging young oncologists who are future leader in the breast cancer, and acknowledged also with the Outstanding Teaching Awards in 2005, 7, and then 11 from the Department of Medicine, Faculty of Medicine, University of Toronto, Division of Medical Oncology. He is also the recipient of Distinguished Alumni Award from the University of Alberta and actively engaged in cancer leadership committees in conferences, advocating for improved patient outcome globally. We have listened to Dr. Sunil Verma many times. I think today again, we will be really enjoying his talk because he is expert in this field, and listening from master himself is really you will be cherishing this experience. Can I ask Dr. Sunil Verma to share the screen and start his presentation?
Thank you so much, Dr. Bapna. Really appreciate those kind words and those welcoming remarks. It's absolutely wonderful to be amongst colleagues from across India, and India always has a special place in my heart. So to be able to come here and share some of our thoughts and our work is really quite an honor. I am privileged to be part of the breast cancer research community for the last 20 years. And it's really been remarkable to see how far things have evolved and how quickly things have evolved. And I share with you our own work that we have been doing over the past many years, collaborating with colleagues, looking at how we can change breast cancer and antibody drug conjugates. Next slide, Kirtan. Thank you. The presentation is about 30 minutes. And over the next 30 minutes, I'll present to you how we are thinking about redefining cancer care at AstraZeneca, really the journey behind trastuzumab deruxtecan in the management, initially of HER2-positive metastatic breast cancer, and then, of course, coming soon to HER2-low breast cancer and beyond. And really, what I'll share with you is some of the insights, some of the learnings as we have progressed the development of this therapy over the past 7 years or so. Next slide. So AstraZeneca is really committed to leading a revolution in oncology to redefine cancer care. I joined AstraZeneca now 5 years ago, and leaving clinical practice was difficult. It was difficult to leave the patients. I was running a cancer center, and really we were building a new cancer facility. But what I felt was that there is a great opportunity for us to really have a clinical voice in pharmaceutical company. And what I was really struck by was these strategic priorities. The leadership team here, including our CEO, we're committed to bringing therapies that transform survival, bringing therapies that really change and revolutionize cancer care. And I'll share, of course, how we think trastuzumab deruxtecan is doing that, improving the patient experience and bringing people and passion and new innovation in the field. And we have really attracted some wonderful people, both internally and working very close, of course, externally, including with many leaders in India. Next slide. And when I joined in 2019, we set forward this 10-year vision. As many of you may recall, there was incredible leaders. There continues to be incredible leaders, but one special person who was at the head of oncology when I joined was Jose Baselga. And I still remember sitting down and mapping sort of the strategy of how we're going to eliminate breast cancer as a cause of death, how we're going to transform the lives. And we had 5 pillars to this strategy. We wanted to make sure that we are able to go in early for those patients who are at high risk of recurrence, that we wanted to be able to not be dependent on traditional tools to tell us when we should be modifying therapy, but look for better ways of therapeutic monitoring for early adaptive intervention. We wanted to make sure that we had precision tools for therapies. And then we also wanted to make sure that we de-escalate traditional treatment paradigms, including chemotherapy. And that was a big focus for us to really bring the antibody drug conjugates forward, and led to not only the development of our partnership with Daiichi Sankyo, which is really critical for both, as you know, with trastuzumab deruxtecan, but also with datopotamab deruxtecan, Dato-DXd, a TROP2 ADC, but also a significant emphasis on our own ADC program. And we have multiple internal ADCs that are coming, including many of them for patients with breast cancer. And finally, we wanted to make sure that we really unleash the power of immuno-oncology. So that became really a blueprint. Next slide. And as we started to really foster, our commitment, we wanted to make sure that we were investing in R&D. And I'm really pleased to share with you, this is just a 9-month view of last year, which was 127 phase 3 registrational trials, which is really remarkable when you think about just the impact and the commitment that we have. And we have more than 50 phase 3 and pivotal studies ready to report in the next 3 years. In breast cancer alone, you can see our portfolio. And our commitment was that we would have a breast cancer therapy across every single subtype, across every single stage, and across really redefining how we look at breast cancer. So you can see here for HER2 positive, in addition to what we will discuss today, Destiny Breast 03, we have Destiny Breast 09, which is in first-line HER2 positive, and Destiny Breast 11 and Destiny Breast 05, which is an early stage disease. In addition, above and beyond the work that we're doing with Destiny Breast 04 and HER2 low that I'll share with you, really looking forward to Destiny Breast 06 that we'll talk about, and of course HER2 low. And in addition, we have multiple studies for looking at our novel SERD compound, Serena-4 and Serena-6 in metastatic, and also a large, one of the most largest programs for adjuvant studies with Cambria-1 and Cambria-2, investing into really understanding how we can reshape early stage breast cancer for hormone receptor positive. And finally, our commitment for HR positive continues with capivasertib 291, as noted up. This was recently approved by FDA, and for PIK3 AKT altered patients and PTEN altered patients. And then, of course, in triple negative breast cancer, moving forward with the commitment to use Dato-DXd as well as capivasertib, both in early stage as well as in advanced setting. And this is on top of course, how we have redefined BRCA-mutated breast cancer with, of course, Olympiad and Olympia showing now an overall survival benefit. So this comprehensive approach across all subtypes, across all settings, was really a commitment that we have that we are going to be here for the breast cancer for the long term, and we're really going to redefine and have a clear leadership ambition in this field. Next slide. As we look forward to our commitment, we continue to build on this commitment by making sure that we have a diverse portfolio. And this is a color wheel that we use, that we look at what are our areas of focus. Our areas of focus are antibody drug conjugates. As you notice here, our own antibody drug conjugates, DNA damage response targeted agents, in addition to, of course, the work that we have done with olaparib. We also have a blood-brain penetrant as well as a PARP1 select agent, and of course, tumor drivers. And you've seen some of the activity that we're seeing with capivasertib with 291. We're really looking forward to the next generation of therapies. And in addition, we have a number of immunotherapies, including cell therapies, immune engagers, and of course, checkpoint inhibitors. So this commitment to make sure that we bring this wealth of our portfolio forward for the benefit of patients is going to lead us to, I think, continued benefit for greater patients and at a greater magnitude. Next slide. So let's bring the journey to trastuzumab deruxtecan. So trastuzumab deruxtecan, of course, in partnership with Daiichi Sankyo, this was a really a unique asset. Many of you may know I was the PI, the global PI for the Amelia study in 2012, when the first ADC came through at that time with TDM1, trastuzumab emtansine, in 2012. And when we first saw this data, and I first saw this data, this was in 2015, 2016, I was really impressed with the activity profile. And what was unique about this antibody drug conjugate was the following. First, we had a topo-1 inhibitor, not a emtansine inhibitor, which was really important. This is a type of course, mechanism of action the breast cancer cells have not seen before. We had a very potent potency of payload, 8 payload to 1 antibody, which is an amazing drug to antibody ratio, along with the potency that we see. We also had a very stable linker payload that I'll talk more about, and a tumor selective cleavable linker. And finally, we were seeing bystander anti-cancer effect, which was really important when we think about the heterogeneity that exists. Next slide. So what's unique about this drug? And I think this slide is really very important. So with TDXD, it binds to the HER2 receptor, it's internalized. However, what happens is the linker is then cleaved within the cell. And when the linker is cleaved, because it's a stable and it's a cleavable linker, the drug is released right into the cancer cell and before the HER2 recycles, which is really very different than what we tend to see with many other ADCs, because what happens is, because of the recycling of HER2 back to the cell membrane, many of the bound payload just gets kicked out. So here, because it's cleavable, you're able to release the drug right within the cancer cell. And then, of course, the bystander effect because of membrane permeability of this payload. So those key attributes, 8-to-1 drug to antibody ratio, ability for cleavable and immediate cleavability, and of course, membrane permeability. So when we saw the initial results, this was in 2016, 61% response rate in previously pre-treated, including patients who had TDM1. We knew this was a drug that was going to reshape. And this was really the reason why I joined AstraZeneca, because I knew this drug was going to reshape breast cancer. I wanted to make sure, as Jose used to say, that we write the textbooks of cancer together. Next slide. So we led to, of course, the conduct of this study, Destiny Breast 03. Many of you know this is in HER2 positive breast cancer patients, must have had previous trastuzumab and a taxane, looking at really a head-to-head, a second-generation ADC with trastuzumab deruxtecan versus TDM1, a drug that I helped to bring forward. So I wanted to make sure that I broke my own record with this study. And next slide. And when we saw the results, it was really remarkable. You see the updated PFS now. With TDM1, the PFS of 6.8 months. As you know, many of these patients had prior pertuzumab, as compared to, of course, the Amelia study. So this is, a current reflection of the current real-world practice. And then you see the PFS with TDXC, more than triple, 28.8 months. And this has never been seen, to have 4 times longer PFS against a really relevant control arm, as you notice here, from 6.8 to 28.8 months with a hazard ratio of 0.33. In addition, what's really remarkable, of course, is the overall survival. And you can see the overall survival of 0.64. And we were just amazed to see the degree of benefit and the degree of activity in these patients who had heavy burden disease, these patients who had a relevant control arm, and how much better and this drug was. And we'll get into some of the side effects, but I wanted to just know that while trastuzumab deruxtecan is a remarkable therapy, and I would say one of the most powerful therapies, there are things that we need to continue to monitor. And the great thing is, when we think about nausea, vomiting, antiemetics work. So prophylaxis works. When we think about ILD, as you'll see, with early identification in Destiny Breast 03, we did not see any grade 4 or any grade 5 ILD rates, which is, again, shows that by effective monitoring, effective assessment, we can prevent the onset of high-grade ILD activities. Next slide. So we were also very interested in the subgroups. We were interested, is the benefit seen across all age ranges? And as you can see here, across the program from Destiny Breast 01, which was a single-arm study, Destiny Breast 02, which was in heavily pretreated study, and Destiny Breast 03, which was in the second, third line, the benefit was very consistent across all age range, patients less than 65 and patients greater than 65. And you see both the median PFS, very similar, as well as the overall survival. Next slide. Looking specifically of interstitial lung disease. Now, this was an important element for me when I was leading this program and developing the program, and also, I think, for the whole clinical community. So in 2019, when we had the first data for Destiny Breast 01, we saw 2.5%, 2.5% grade 5 ILD rates. And we said that is just not acceptable. That is not the right thing for patients. That is not the right way of bringing this therapy to our clinical community. And we need to do a lot more. So when we saw with Destiny Breast 03, with effective monitoring, with effective education, ensuring the patients were managed in an appropriate manner, we saw 0 grade 4 and grade 5 rates. And that really shows that monitoring and early management leads to an improvement. And furthermore, there is a slightly greater risk in patients who are over the age of 65, but again, in earlier line setting, we did not see that higher risk in DESTINY-Breast03. Next slide. So we were also really interested to ensure that we learn about activity of course, antibody-drug conjugates in patients with brain mets. Many of you know that there was sort of this notion that because of a larger molecule, such as an antibody, you may not be seeing as strong an efficacy. This was the case, of course, with TDM1 in patients with brain mets. But we were curious because we were seeing some anecdotal responses. We were seeing responses that the clinical community was sharing with us of this drug working remarkably well in patients with brain mets. Now, in DESTINY-Breast03 and 01 and 02, we included patients who treated stable brain mets, and there were also a subset of patients who had untreated and active brain mets. And you can see here that irrespective of treated stable or untreated active brain mets, compared to the control arm, T-DXd does much better. Now, specifically, if you go to the next slide, we looked at that response activity. And what's really remarkable, you can see compared to even trastuzumab capecitabine or lapatinib capecitabine, a traditional treatment that we would have otherwise considered for patients with brain mets, the activity profile with T-DXd is just remarkable in patients with brain mets. You can see the response rate with nearly 40% of patients having a complete response, and the overall response rate was around 60% to 65% in heavily pretreated patients with brain mets. Now, if we go to the next slide, this continues to be seen in some of the ESRs and also continues to be some of the investigator-initiated trials that we have now seen. You can see here in the Tuxedo 1 study, which was led by Dr. Barsh, published in Nature Medicine, in patients with newly diagnosed brain mets or progressive disease after prior radiation therapy, we saw a 73% intracranial response rate with trastuzumab deruxtecan. Furthermore, in patients with even leptomeningeal disease, you see a significant activity with patients with trastuzumab deruxtecan. And I know many cases that the clinicians have shared with us in patients with brain mets where the disease resolves and responds very quickly. We're working very extensively with a number of institutes, including a number of neurosurgeons, who are just amazed at the degree of activity and how well this drug works. Now, why does it work? I think it's the blood-brain barrier has been perturbed, and I think the activity of this drug allows it to really reach the brain mets, and you see this remarkable activity profile in patients with brain mets. We will present some more updated data on patients with active brain mets through the course of this year, but really the early signals look very encouraging. Next slide. So in addition to, of course, HER2 positive, we were very interested in HER2 low breast cancer. Now, HER2 low breast cancer was a terminology that we came up with and we coined along with the clinical community to really understand, is HER2 disease a spectrum? And when we think about HER2 negative and HER2 positive, we have very well-established guidelines. And we were really interested to say, can we look at HER2 low expression as also a marker of efficacy with patients receiving trastuzumab deruxtecan? HER2 low as defined by IHC 1+, 2+-ish negative. And as you can see here, for HR positive breast cancer, that's nearly 65% of patients who are HER2 low. For triple negative breast cancer, that's probably about a third, but about 65% of all HR positive are HER2 low. So next slide. So The preliminary data that we had from a study called J101, which was really a phase 1/2 study, showed in patients who had, at that time, we had 47 patients, 54 patients in total, but 47 patients who had the 5.4 milligram dose, we were seeing activity. We were seeing a response rate of around 35%. We were seeing overall PFS of around 10 months. And that sort of suggested to us that this is probably real. Now, just based on those 50 patients, next slide, we decided to conduct the DESTINY-Breast04 study. This was in patients with HER2-low IHC 1+2+, who have had prior lines of chemotherapy, 1 to 2 lines, could have had HR-positive disease or HR-negative. And we looked at T-DXd versus physician treatment of choice, head-to-head comparison, to look at standard chemotherapy versus T-DXd in patients who have IHC 1+2+. And of course, next slide, this data was presented at the ASCO 2022 plenary session. And as many of you who were in the room, this was a standing ovation. It was a standing ovation for this data, but really it was a standing ovation to show that we are really shifting away from chemotherapy in breast cancer. And that's really a start to shift away from chemotherapy in multiple other cancers. And also, this was the first time that we were using a biomarker to tell us which patients benefit from an antibody drug conjugate, where the biomarker was not really a biological phenomena, but it was a therapeutic identification biomarker to say, if you have this biomarker, you're more likely to benefit. And the benefit, as you can see here, with a hazard ratio of 0.51, nearly doubling of the progression-free survival in HR positive, and similarly in all patients. Next slide. So this has since been updated, and the update, as you can see here, continues with 32 months follow-up that Dr. Shanu Modi presented at ESMO last year. And you continue to see the separation of the curves, and you continue to see this remarkable benefit of 9.6 months versus 4.2 months in patients with HR positive, and also including in patients in HR negative. Next slide. But in addition to, of course, the PFS, the reason for the standing ovation was also this data, updated overall survival, which also shows a remarkable benefit, showing an improvement in overall survival versus standard chemotherapy. And that benefit is now seen across HR negative patients as well. You can see that those patients who are HER2 low and HR negative would be traditionally classified as triple negative breast cancer. You can see that the PFS is 2.9 months versus 8.5 months, and the overall survival also doubles with a hazard ratio of 0.48. So irrespective of HR status, if you have a HER2 low patient, certainly trastuzumab deruxtecan is better than chemotherapy for PFS and overall survival. Next slide. So I wanted to spend a little bit more time, of course, on ILD. Now, there's a great question by Dr. Chandrakanth to say, is ILD a phenomena related to later lines of therapy? So what happens is the following. When we have later lines of therapy, there is no doubt that there is a slightly greater risk of ILD. But what we saw when in those patients who had grade 5 events, in late line treatment, clinicians are just not as aggressive in managing those patients. So when patients died, they died likely because of progression of their underlying disease, but because they also had ILD at that time, our adjudication committee said, well, this could be ILD related. We cannot really exclude that. So it was attributed to ILD, but in many cases was really because of progression of disease. So when we think about late line, I think it's really the patients may be more fragile. So the disease progression itself is likely more the causality of them dying, and less so the ILD. But because it cannot be clearly delineated, we always attribute it to the ILD as per the adjudication committee. So that's really important. So the second thing the question that's come up is, Have you seen any cases of MDS? No. To my knowledge, we have not seen cases of MDS. It's a great question, of course, with the topo mechanism of action. So we have not. Are there any overlapping lung toxicity of TDXD and TDM1? So of course, we would never combine it, but in sequence, we're not seeing any greater toxicities for patients who have TDM1 after TDXD. So we have not seen any reports of that. And of course, why and how does this toxicity happen? So we have seen this toxicity with this mechanism of action across the program, including with Dato-DXd. Now, there's many suggestions. It's not related to HER2 expression. I don't think this is related to underlying lung disease. I think it's probably related to, of course, the payload, where there's some degree of release of the payload in the lung parenchyma. So appropriate management, appropriate intervention, appropriate recognition can lead to low grades of grade 3 and higher ILD. And I think that's really very important. There's another question. I'll keep answering them. What about after progression TDXD? So we are looking at all that data. As you can see, even after progression of TDXD, patients could have had TDM1, but despite that, the overall survival in DESTINY-Breast03 is remarkably better. And then the post-progression survival is also quite a bit more after TDXD. So the PFS was 28.8 months. The overall survival, of course, exceeded 50 months. So many patients go on to still receive benefit from other anti-HER2 therapies. So because of all those reasons, I think using it earlier is likely safer. Using it earlier gives you the greatest benefit, and using it earlier still allows you to have potential activity with other drugs post TDXD. All right, lots of other questions I'll come to maybe later. Let's continue on. So the other amazing thing from DESTINY-Breast04, and this really did surprise me when we first saw this data, is what about the activity in IHC 1+ versus IHC 2+? So you would think that there is, of course, benefit that we're seeing, that there will be some degree of variability, and there was no degree of variability. The benefit was consistent for response rate and PFS across IHC 1+ and IHC 2+. Now, IHC 1+ is still thousands of HER2 receptor. IHC 2+ is hundreds of thousands of HER2 receptors. So that may be just enough for this drug to get in. Next slide. Of course, across all the other subgroups, when we take a regardless of lines of therapy, the disease burden, the rapid progression, whether patients have had CDK4/6 or not, there was a clear benefit favoring TDXD over chemotherapy, which really is absolutely remarkable when you have a hazard ratio of 0.5 against a very active drug. Next slide. So we continue to, of course, learn about HER2-low disease. Now, I think it's fair to say that there does not appear to be a prognostic effect of HER2-low status. That this is not a biological phenomena, but it's really a therapeutic identifier and a predictive marker and not a prognostic marker. The other thing that's really important is that HER2-low is a dynamic state. And so we always recommend the patients in the metastatic setting should be rebiopsies to confirm the HER2-low status, because HER2-low and HER2 expression does vary, as we very well know, between early stage disease and metastatic disease. Next slide. So we also understand that HER2-low testing needs to be really done in a very standardized manner. So we always ensure that appropriate education for the pathologist is critical here. And you can see that there was discordance that we saw between central testing and local testing. However, the benefit was seen irrespective of whether it was the testing was done on a primary met or metastatic met. But we always recommend to do another metastatic biopsy to, again, look for any evolution or any changes in HER2 status. Next slide. So given this wealth of data that we've seen with DESTINY-Breast04, of course, gives us great reflections and, of course, anticipation for this pivotal study, DESTINY-Breast06. DESTINY-Breast06 now is in chemo-naive setting. It's only hormone receptor positive. In addition to coming earlier line setting, we also are now looking at, of course, a different comparator with different choices of chemotherapy given its first line. But more importantly, we're not only looking at 1+, 2+, but we're also looking at patients who have what we define as ultra low, which is IHC 0 with membrane staining, but it's less than 10%. So we have shared that we expect the results of this study in the first half of this year. So really looking forward to having more information on this study. Next slide. There is, of course, early signals from Fabrice Andre and the IGR group that there may be activity seen in patients at least in IHC 0. So you can see the cohort 3 there, which is HER2 non-expressing, and you're seeing activity and response rates even in those patients. So we are eagerly anticipating, of course, what level of activity we're going to see in earlier line and what level of activity that we see beyond 1+ and 2+. Next slide. And again, I wanted to just underscore the importance of monitoring, importance of early assessment, importance of effective steroids and the right appropriate dose of steroids. So to make sure the patients see this remarkable benefit of this powerful drug, but also we ensure the safety of these patients to ensure that there's no grade 3 or higher ILD events. Next slide. So I wanted to just leave you with a couple of other things is for management guidelines. For asymptomatic ILD, again, our recommendations is to consider corticosteroid therapy at the dose noted here, and then to withhold the therapy until recovery to grade 0. For symptomatic, and symptomatic is basically any symptoms that you should initiate corticosteroid therapy immediately. And we recommend right now to discontinue trastuzumab deruxtecan. We're doing studies about re-challenge, of course, with many investigators, but until we see those results, for those patients, about 10% of patients who develop grade 2 or higher, our recommendations is to discontinue trastuzumab deruxtecan. Next slide. So the final thing I want to leave you with, next slide, please. I think we've covered, is that there is guidelines available, and I would really recommend to all of you to ensure that, when dose modification is needed, to ensure you have access to high-resolution CT pulmonologists, that you ensure that other causes other than pneumonitis are ruled out, and to ensure that the appropriate management guidelines are followed. And with this, as we have shared with you previously in DESTINY-Breast03, when you follow it, grade 3 and higher ILD events should not occur. So that is really, I think, the key learning for us across the program. Next slide. So these are our recommendations. So high resolution CT at least every 12 weeks or every 6 to 9 weeks if there's baseline respiratory symptoms are recommended. And of course, as noted, the patient should be informed to contact if they have worsening shortness of breath or cough or any new pulmonary symptoms so that we manage those patients appropriately very quickly and, of course, ensure that patient safety is paramount. Next slide. So I want to really conclude and thank you again for this remarkable opportunity. I am so very pleased to see how we have redefined breast cancer. HER2, which was a marker which was first identified in the 1980s as a prognostic biomarker, and of course, trastuzumab, which has changed how we treat early stage breast cancer, metastatic breast cancer, and now to bring a new therapy that has now really revolutionized breast cancer, both in HER2 positive, but then redefined breast cancer with a new HER2 low biomarker, showing improved therapeutic benefit is an honor of my lifetime to be able to be part of this journey and to bring this therapy. And I just encourage all of you to use this drug safely, effectively, and I hope patients continue to benefit from this therapy, and we continue to improve the lives of patients across the board. So with that, I'm happy to answer all the questions which were coming up, and I'll pass it on to Dr. Bapna to let me know how much time I have to answer any questions. Thank you.
Thank you very much, Dr. Sunil. It was an excellent talk, and we were expecting and anticipating the same with you. And you have made the most difficult task. You have converted it into a very interesting topic. Almost it was like a storytelling, and from the beginning till end, you have taken us through the journey, how it was developed, and how it has given us the a new era of hope for these kind of difficult to treat patients. And I really thank that you have taken the question in between. I have answered most of the question. So there are one or two more questions that whether it can be in the upfront setting can be combined with the CDK4/6 inhibitor in hormone receptor positive HER2 low tumors.
Sure. I'm trying
Combination
to.
of CDK4/6 with TDXD.
Yeah, great question. Great question. So, at the present time, we don't think it's combinable. It's not combinable based on two factors, based on really overlapping neutropenia. So if we may see enhanced neutropenia, of course, with CDK4/6, and that's going to be a challenge. So we are looking, and we're very interested to identify those patients who we think may not benefit from CDK4/6 in the early line setting, and then to see can we bring trastuzumab deruxtecan against versus CDK4/6 for those biomarkers, identify patients that are unlikely to benefit from CDK4/6. That's an active area of discussion with a number of academic groups right now for us to design such a trial. So you'll really anticipate to hear more about such a study very quickly.
Yeah. So second question is there a high risk of lung toxicity when administering TDXD in later lines compared to earlier lines?
Yeah, I was addressing it a little bit, Dr. Bapna, as because underlying disease progression tends to be a bigger factor in patients who have later line therapy. So it's really hard to distinguish, is it ILD or is underlying disease progression in late line setting? So our adjudication committee, that we have adjudication committee for all ILDs, they tend to attribute that to ILD, but in many cases, because it's underlying disease, it's hard to tease out. But I do feel that there is likely a greater toxicity and more heavily pretreated. So that's why we suggest, earlier utilization, so that we ensure that the lungs are not primed for a greater likelihood of toxicity.
So you mean to say sooner the better?
That's right.
So how do you put this Destiny trials in active brain metastasis vis-a-vis HER2 trial?
Yeah, so our activity, of course, looks really strong from Destiny Breast 03, even when it compares to HER2 Climb study. We have conducted a very large study called Destiny Breast 12, specifically in patients with active and progressive brain mets. We expect the results of this study later this year, and I think that will solidify our belief that this is a better therapy overall, even when we reflect the HER2 Climb data.
So this question you have already answered. So my next question is that as happening with the other NABs and MABs, there is often a tendency in MLICs to there is a tendency to go towards the using the low doses, which is a recent concept. So is it going to happen with this as well? Is there any data that in the dose finding study that even the low dose can work somewhere?
It's a important question. When we took a look at the initial activity profile, certainly the 5.4 milligram dose was the right dose, and as you do that with trastuzumab or you do that with other therapies, after a year, we're very interested to say, after a year, can we change maybe the schedule instead of every 3 weeks to every 4 weeks? So that's the most important question that's coming. So we're likely going to do such a trial, but for now, majority of patients are able to stay on treatment. We have patients staying on treatment 3, 4, 5 years, now, of course, from the pivotal study because of the benefit. But should we modify the schedule after 1 to 2 years? Should we modify the dose? It's an important question that we were likely going to evaluate, but for now, I would say standard dosing is appropriate for those patients who are experiencing some side effects like fatigue. Going every 4 weeks is probably advisable after initial 1 year of therapy.
Okay, wonderful. So okay, there is another question on the screen. In spite of higher tumor specificity, why ILD more common with TDXD?
Yeah, I think it's the potency of the topo-1 inhibitor. I think that's what it comes down to. It's a very potent inhibitor, and that's likely what's causing some of the toxicity that we're seeing in these patients.
So let us keep some questions for panel discussion as well, because you will be bombarded there as well as you have been just now. So may I take the opportunity to invite the moderator of today's program, Dr. Amish. Amish, are you there?
Yes, I'm there. I
Hi,
have
Amish. How are you?
myself. Hi, how are you?
Yeah. Yeah. So Dr. Amish actually doesn't need any introduction. He's a very senior medical oncologist and co-founder and head of oncology of Hope Oncology Care Clinic. And beside this, he's the man behind the most prestigious academic program of India, OBTO. So that I really need to mention. Without mentioning it, your introduction will be complete. I hand over the further proceedings to our moderator of this session, Dr. Amish Vora. Amish, please take it forward.
Thank you, Dr. Bapna, sir. That was very, very kind of you to talk about OBTO.
Yes.
We are quite happy the way it has shaped up. So just taking forward, before we go on to our first case, I would like to name out our experts for today. We have 9 experts today. So what we have divided is that first 2 cases, we will have 5 experts. And the next 2 cases, we will have 4 experts. So in the first 2 cases, the experts are Dr. Manish Singhal, Dr. N.K. Warrier, Dr. Vamshi Krishna, Dr. T.P. Sahoo, and Dr. Meenu Walia. And for the next 2 cases, we will have experts as Dr. Joydeep Ghosh, Dr. Ullas Batra, Dr. Manasi Shah, and Dr. Amit Rauthan. We have it's a 7:20 right now, so we have 1 hour and 10 minutes for 4 cases. So I'm not going to show any slides because otherwise we will never finish on time. And we have experts, although I have all the papers in front of me. If we want to discuss something, we can go to that. With that, I would ask Dr. Akhil Kapoor to give synopsis of the first case. And Akhil, less than 5 minutes, better, then we will have 15 minutes for discussion.
And Dr. Vora, just before Dr. Akhil started, I will take my leave because I have to join another meeting. But I just want to thank everyone for giving me this opportunity to participate and join you. And as always, I'm here at your service. Anything I can do to help improve the outcomes of patients and the breast cancer community in India, it would be an honor to support. Thank you, everyone.
Right, Dr. Verma. Take care.
Thank you. Bye-bye.
Thank you, sir. So I think I will proceed in the interest of time, and I will try to keep it short and sweet as instructed by Amish, sir. So, this is a 33-year-old lady presented with breast cancer, T4B-N2 disease at the baseline. She was ER very low and HER2 positive 3+. She received the standard treatment, the chemo TRUST-2, followed by AC protocol, underwent BCS, followed by has residual disease YPT4N1. She received trastuzumab maintenance and tamoxifen along with radiation. After a year, you can see this is a journey of 2020, and then it came back in 2022. So close to 30 months of diagnosis. The patient developed a recurrent lesion in the breast as well as the lung lesions. A biopsy was done. It was ERPR negative, HER2 plus fish was non-amplified. So baseline HER2 plus, baseline HER2 plus, then in the first recurrence, it was HER2 non-amplified, HER2 plus on. So she received chemotherapy, she had some responses, but after progression, she was challenged with another drug, eribulin, had poor responses and had grade 3 PN as well. At the same, in the middle, an NGS was done and showed a BRCA1 mutation, which was not done at the baseline. She also developed a lesion in the brain and also had leptomeningeal disease. She received radiation and she was started on olaparib, and she had tolerated it not so well, but yes, it was fine. And she had grade 2, grade 3 toxicities, myelotoxicities, which is expected with olaparib. Around 5 to 6 months later, a scan showed a stable disease. But after further 3 months, so close to 10 months on olaparib, she developed significant headache. It was thought to be due to radiation necrosis. She was given bevacizumab for the steroid sparing effect and relieving of intracranial tension. She had some benefit. There was one new lesion in the brain. Other lesions outside the brain were controlled. She received stereotactic radiotherapy to the brain, 20 grain 2 fractions. But later she developed clinical progression, and she was started on treatments with capecitabine and cyclophosphamide, as she was not very willing for IV chemotherapy at that time. She had a stable disease clinically for some time, but later again, it had progression in the brain and she had significant symptoms. I will be showing the images in the next slides. Since the patient was HER2 plus fish non-amplified, in which was the biopsy done around 1.5 years back, and she was not responding well to the treatment, we thought of doing a repeat biopsy, but at least the patient had HER2 plus disease. So that was a consoling point that we can opt for trastuzumab deruxtecan. And she was started on trastuzumab deruxtecan. Meanwhile, a biopsy was also done, and the biopsy came as HER2 plus actually. But she had already received one dose of trastuzumab deruxtecan till time, and that was continued. You can see the images. This was the images of the local site, the PET-CT imaging. You can see the large lesion in the breast, which was very symptomatic. It was having significant discharge as well. But later, after 3 doses of trastuzumab deruxtecan, it had significantly improved. At the same time, if you see, this is the lesion in the brain. You can see there's a large significant lesion with lot of edema, which it has already received 2 times radiation, once whole brain radiotherapy and second time stereotactic radiotherapy. A large lesion with significant peritumoral edema. It had significantly shrunken and patient neurological function improved significantly. So the patient who was multiply treated with multiple lines of chemotherapy, at the same time, the patient had intracranial progression, which was the most common symptom, and that was the leading cause of the symptom for this patient. HER2 was dubious, sometimes changing to 2 plus and fish non-amplified. But since we have the data of even utilizing TDX in HER2 low also, it gave us confidence to start TDX. By chance, it came as HER2 plus, and the patient had good response in the brain, as evident in and the patient is on now 6 doses of trastuzumab deruxtecan, and she's doing clinically and radiologically well. So I think I try to finish the presentation, and then we can have some small discussion, sir.
Thank you, Dr. Akhil. It was a very crisp presentation, very nice. Your point of contention, what I feel are in this particular case is 3 variable HER2 expression. That is 1. Second, your patient kept progressing in the brain more rather than in the systemic illness. And third is, could we have used trastuzumab deruxtecan or tucatinib in 2024 little earlier? We have another 12 to 15 minutes for this presentation. So I would like to ask all the experts give answers in brief so that we can learn from each other. Let me start with Dr. N.K. Warrier. Dr. Warrier, sir, you are on my screen. A simple question which I am asking you. See, the HER2 3 plus becoming HER2 2 plus or HER2 1 plus is a very well-known phenomena. In a similar phenomena, we also have seen in rituximab early on when CD20 become positive, become CD20 negative. So that is not something we are going to debate and discuss. It's a well-known phenomena. My question to Warrior sir, to you, to Dr. Vamshi, Meenu ma'am, Tarini, and Dr. Manish is, if I have a patient of locally advanced breast cancer, the first biopsy shows HER2 positive. I have given TCH. The surgery is done. There is a residual disease, which is HER2 negative and non-amplified on fish. Would you give TDM1, yes or no, in this residual disease, Dr. Warrior?
At the moment, I will not, because the capecitabine is one of the choices given. So probably because the HER2 low and it is non-amplified, though there are even the HER2, the zero HER2 TDM1 has the deruxtecan has shown effect, but at the moment I will be very skeptical unless we have more data from that the cohort 4 which the Sunil Verma was showing. Right now, I will be very hesitant.
So, Dr. Warrior, you would not give TDM1 in this particular patient. Vamshi, would you give TDM1 in this patient?
I would. The only thing is, if I have done the HER2 in some other lab, possibly I would like to do a fish again just to confirm in the original biopsy.
It's
But
a
yes,
confirm that it's a conversion. It is a down regulation of the receptor. So
I would
Vamshi will
still
give.
I would
Dr.
still
Warrior
give.
would not give. Meenu, ma'am, would you give TDM1 in this patient?
Again, I mean, that once that point is clear that we have reconfirmed the original specimen,
Yes,
it is
yes.
still HER2 positive, I will give.
So HER2 positive becoming HER2 negative from after NACT, you would still give TDM1 in residual disease, Meenu, ma'am. Is that correct?
Yeah, I will still give, although a very interesting question, because tumor heterogeneity is a known factor. So
Right,
whatever residual disease possibly is, even if it is HER2 negative, I think I will err on the side of over-treating than under-treating.
And you would give. Dr. Tarini,
Same here.
you would give 1:3. Dr. Manish Singhal. Do we have Dr. Manish here?
So Dr. Manish
Because
is not logged in.
Dr. Manish has not logged in. Whenever he logs in, you let me know. So, Akhil, going by the corollary of what we have seen, and majority of the panelists, and including myself, because there was a biomarker analysis in the Catherine subset, which the slide presentation is there. I can send it to you. They did not stop TDM1. They did not stop anti-HER2 treatment if the positive biopsy became negative biopsy. So anyway, so there is a nice biomarker analysis PowerPoint presentation which says that you will not stop anti-HER2 if in the journey becomes negative. So Tarini, come back to you. Akhil treated his patient in between with 2 different lines of chemotherapy because his HER2 became 2+. Only chemotherapy followed by only chemotherapy followed by olaparib. Tarini, today in 2024, would you have treated this differently? Because there was an 18 months of PFS when the first MET happened and HER2 was 3+ to 2+. Tarini.
Yeah, 2 things. I don't feel this patient was treated by Akhil. You would have not skipped HER2 therapy, knowing him. So I strongly believe I would have given an anti-HER2 agent. And that's my very clear take on it. Would it be a dual like the Cleopatra, or would I have gone for a TDM1 at that point of time is something I can debate upon. But given today a choice, in this patient, I will err towards, because the patient presented with the brain mets. That's what I feel. That was the first relapse site. I would err towards either a Hercline type of protocol, or I would probably go towards a TDXT.
Okay, so you would say either tucatinib or TDXT in this patient early on, and you would not have stopped anti-HER2 ever in the journey. Am I right, Tarini?
No. Yeah, that's the point. Yeah.
Okay, Vamshi.
Agreed with Dr. Sahoo. I think
No, Vamshi, my question is different. I know we all agree with Tarini all the time. Vamshi, the Destiny 03 allowed patients to be used upfront in TDXT if less than 6 months of adjuvant or neoadjuvant patient progressed, right? In this particular patient progressed after 18 months, approximately 18 months. But going by, say, HER2 2+, and you have an opportunity to grab this patient on TDXD, would you go with TDXD or would you still go for the label and will give TDXD little later on?
So I think we will go with TDXD. I mean, I'm not really getting your point. 18 months on therapy in second line, it becomes a second line. So it is eligible as per the label also. So I would give the
No,
TDXD.
it is not the second line. Ideally, Destiny 03 said that second line in metastatic or the first line trastuzumab stroke pertuzumab patient
Correct.
progress within 6 months.
Correct.
So this
That was
patient
a-
has still not received anything in the first line metastatic setting.
No, patient received trastuzumab, right?
Patient received in adjuvant setting. Akhil, am I right?
Correct.
Correct. An adjuvant setting.
So Vamshi, point is that suppose assuming inclusion criteria is not met, would you shift the 3DXT early in this particular patient because now you have HER2 as 2+ and not 3+ and FISH negative?
Okay, so you're asking two different questions, Dr. Amish. One question is, are you treating like a HER2 low? If you're treating like a HER2 low, then possibly chemotherapy is a better option. If you're still treating it like Dr. Sahoo said that once HER2 positive, you're going to treat it like HER2 positive, then yes, continuing TDHD would make sense. I think the 6 months is the trial inclusion. Logically,
Yes.
if something is working as 6 months and somebody comes at 5 months, you're not going to say that, no, it's not 6 months, I will not give. Because the same cutoff of 6 months was used in the TDM one as well. So then you are stuck with something with saying that,
right.
no, we will not
Vamshi, you raised a very important point. And Meenu ma'am, assuming that we do not follow the label and we say that this patient, I would like to give TDXT, what's the difference between 1 month and 2 months? And if we have grade 5 ILD, what would you in the hindsight look at? My point is, should we in our clinical practice stick to the proper label and inclusion exclusion criteria, or little leeway is allowed? It's a very famous child book score of A and B7. You will go crazy if you want to dissect. But here in breast cancer, would you agree with Vamshi that in real life it is okay to tweak inclusion exclusion a little bit?
But the fact is, Amish, that in real life we always tweak. And we have to tweak because you will never have that all those clinical trials copy paste patients. So I would definitely feel that tweaking is required. And then if the toxicity comes, then toxicity would have come with anything else also and maybe earlier also. And if you are thinking of the toxicity, probably earlier you use, better it is. But I would have used in the same this thing,
You would
and
have
I
used
have
in the same
definitely
case.
tweaked also.
Warrior, sir,
Yeah.
Dr. Warrior,
Yeah,
would you
yeah,
have used TDXD earlier in this patient?
definitely. After the Destiny 03, I feel that if I get a similar clinical scenario, I will be using TDX earlier. The reason being, again, it has shown demonstrated excellent response after pertuzumab the combination.
Okay, perfect. Tarini, the last question to you. And before that, I would say that in my clinical practice, this patient does not qualify for the first line metastatic disease with TDXT, and we do not have the label. So I will be reluctant to use this particular patient upfront on TDXT, but that's how I practice. Tarini, the last question, Akhil's patient kept on progressing brain. Where would you put tucatinib versus TDXD in this patient? And then we can move on to the next case.
Yeah, very clear thing. I strongly believe if you look at the HER2 climb, there have been patients who have been pre-exposed to, and it's ideally a third line therapy for me. So I take it as a point that I will probably use a tucatinib post TDXT because it looks like tucatinib is still very active in the patients who have been exposed to pertuzumab 100%, trastuzumab 100%, and TDM1 100%. So I will take that opportunity and give XD initially, and then keep tucatinib to the next line.
Okay. Akhil, since Manish is not there, you act like Manish. The hazard ratio of tucatinib versus TDXT. in the various destiny trials is almost similar, 0.6 to 0.55 in brain mets. And there is a meta-analysis which Dr. Verma showed that in a meta-analysis of Destiny 0, 1, 2, 3 and Tuxedo and other trials, it is working actively well. Where would you put your patient now if you have to revisit in 2024? Where is tucatinib? Where is TDXD? Tucatinib third line, as Tarini said, but there is a caveat that the FDA said that if there is active brain mets, you can go in second line tucatinib also.
So, sir, I would like to see that most of the time patients are just immediately after treatment with either trastuzumab or trastuzumab plus pertuzumab. When we are using HER2 data, we have to combine with capecitabine and trastuzumab. So I'm at loss by understanding the mechanism when patient has clearly progressed on one of the treatments. Then it is how does it make sense to continue that treatment and add one more drug to it? So I am not very confident about using a patient who is already on Trastu or Per2 or Trastu plus Per2, then exposing to tucatinib plus along with Cape and Trastu. If in this patient, the patient was not on trastuzumab from a longer duration, here it would have been okay for me to utilize tucatinib plus capecitabine plus trastuzumab. But if the patient has progressed on such drugs treatment with trastuzumab, it would not make me much more clinical sense to add tucatinib and continue the previous treatment and add capecitabine. So that is my take from the logical point of view. I completely agree with the available data. It is not so much different, but from the clinical experience, we have imported tucatinib, we have imported TDX in a large number of patients, and all the patients had brain mets, all close to 17 patients where we utilized both tucatinib and TDX. We have our own experience. So going by the initial experience, I do not find it tucatinib to be so much responsive in brain mets as experienced with TDX. But just one point, it has a small experience of 17 patients.
Agree with you that TDXD is equally active in brain metastasis. Although the meta-analysis had a pooled data of Destiny's various, while HER2 climb was selectively, 50% of the patient had CNS mets. And at the time of data cutoff, I'm saying this sentence because the AZ said this is a non-promotional activity.
Dr. Amish, you are on a mute probably.
Yeah, I'm getting lost again and again. My apologies. My Wi-Fi shows I'm very much attached to the internet. Something wrong.
AZ is making you get lost on this meeting.
मुझे लगा तारिणी बोलेगा यही. So with that, just last point is at the time of data cutoff, HER2 client had 36 patients on treatment, out of which 35 were on tucatinib. So tucatinib also is a very potent CNS drug. But yes, the take-home message is TDXD at this point of time.
The
makes
last
perfect
point which I wanted to
Okay.
make, not a tucatinib has a strong data of her to climb. The Debra, which is a small data set, I just want to tell you in the progressive patients also, if you look at the cohort 3, they still had a good response intracranial of around 45 to 50%. So that makes that TDXD is a very active drug in the brain. So that is something very
Absolutely.
comforting actually.
Absolutely, Tarini. I completely agree with you. And with that, let's move on to the next case. Can I request Dr. M.V. Chandrakanth to present his case in next 5 minutes or so?
So thanks, thanks, Amish sir, for that very nicely moderating the last session. I would thank Astra for this opportunity. So I will something similar, but not completely similar. So this is left side of the one is a clinical trial patient, and the right one is a real world patient. So this is an example of how we can treat a HER2 positive metastatic breast cancer. So this is a 37-year-old lady in March 2021, had a left breast lump and uh, back pain weakness. Clinically, she had a 3 centimeter breast mass with a left axillary lymph node and D1 tenderness, and she was performance status 2. And the baseline labs did reveal some low hemoglobin, and the albumin was 3 and the creatinine was fine. And the core biopsy of the left breast lump revealed a HER2 2 plus, and the fish was amplified. And you can see the fish picture right on the right side, and the ratio crossing 2, that is, it is positive. So it's a HER2 positive, ERPR negative disease, and the baseline staging did show a left breast mass, left axillary lymph nodes, mediastinal lymph nodes, retroperitoneal lymph nodes, extensive bone metastasis, and bilateral adnexal masses. So this patient, to summarize, HER2 positive metastatic breast cancer with a preserved ejection fraction. Patient went on to Cleopatra for 6 cycles, and this is what you would expect, and this is what near complete response with the Cleopatra regimen. So these are the PET images showing near complete response. And then the patient went on to receive 28 cycles of HER2 trastuzumab maintenance. And then she developed disease progression with left axillary lymph nodes, no new bone metastasis, adnexal mass, and so on. You can see the PET images and the CT images also. So then we should have rebiopsied. However, 3 cycles of TDM1 we gave, and the patient developed symptomatic worsening and the PET showing frank disease progression. So new bone mets, new axillary lymph nodes, increase in adnexal mass, which you can appreciate. So now we did a rebiopsy. Now the rebiopsy is showing that it is not amplified, and the ratio has fallen to 1.87. So HER2 fish positive now becoming fish negative as per the criteria. So we gave 3 cycle KPLAP, stable disease, and then total 6 cycles of KPLAP disease progression. And then we gave 1 cycle of gem carbo-tras2, worsening pain. We were in the process of procuring TDXT, and that's the reason why this all happened in between. And we gave TDXT for this patient post 3 cycles of TDXT. The left part of the image is the new one, and the right part is the old one, showing partial response. So just to have a salient landmarks, 37-year-old lady, metastatic breast cancer, HER2 amplified, 6 THP PR, 28 PH PD, 3 TDM1 progression, rebiopsy, ERPA remained the same, HER2 was 2 plus again, and HER2 remained non-amplified this time. IHC was 2 plus again. And then we gave 6 cycles KPLAP progression and 3 cycle TDXT PR. And these are the points which may help Dr. Amish to discuss. Thank you, sir. So you're muted.
Thank you, Dr. MV. That was a very, very nice. I think both you and Akhil, because you both are young, you selected the young breast cancer patient. Both the patients were less than 40 years of age, but yours is metastatic breast cancer to begin with, while his was, adjuvant treatment, and later on it was there. So again, Destiny 01. Let me start with Meenu ma'am. Ma'am, Destiny 01 had included large number of patients who were treated with TDM1 earlier, and it still showed a 60% response rate. So Destiny 03, while compared TDXT and TDM1. In this particular patient, I think what Dr. Chandrakanth has followed a standard textbook pattern of the treatment. Would you give earlier, rather than TDM1, would you have given TDXD in this patient?
In today's date, no. Yes, I would have given TDXT. Now we see the data also is more encouraging and going by the standards. I mean, now that it is available, but probably when the patient was treated, we didn't have TDXT in our country. So anyway, I would have given TDM1 at that point of time. But if today I have the option of both the molecules, I would rather give TDXT rather than TDM1 in this slide.
Right. Warrior, sir, the TDM1 failed in this patient miserably. While lab cap worked, And while Gemcite carbo trastuzumab followed by TDXD worked. Why do you think this happened, this phenomena?
Yeah, that was very interesting, but it's a well known that the initial combination and dual anti-HER2 will lead on to resistance to TDM1. What they have found out was about 30 to 40% of patients had developed resistance, and uh, because of the various reasons, and it's good. And very often the combination, the dual anti-HER2 will end up in resistance to TDM1.
Okay, Vamshi. Vamshi, are you there or you left?
No, I am there.
Okay, Vamshi, Sarka 2012 Emilia trial, TDM1 versus LabCap, median PFS 10 months versus 6 months or 6.2 months. In that particular, it was exactly the same, second line LabCap versus TDM1. This particular patient fitted the bill for Emilia. Would you have treated differently this patient? If TDXD would not have been available, would you have given TDM1? And why do you think that TDM1 failed in this patient?
So I would have used TDM1 because that would have been the standard of care. Why it failed? Yes, there are resistance pathways we know, and more importantly, that HER2 2+. And in fact, Chandrakanth raised the same point. Should you have rebiopsied after the THP? Would it still have shown a HER2 2+? Are we looking at some target? No, the localization might not have been as good. We know with TDXD there are two resistance mechanisms, mainly, both the target linkage is affected or the target is affected. So it was maybe a HER2 variable at that point of time, which is why the TDM1 did not act. I mean, that's just a theory. Why did LAP and CAP act if the TDM1 did not act? I really don't have an answer to that.
LabCap is also 2+, fish non-amplified, and it worked. Although it worked for a short, worked for 6 months, that's what MV said. Tarini, in today's age and world, Destiny 03 allows you to use TDXD in second line. Do you really think that we should biopsy anymore in this setting? TDXD not there. Yes, biopsy, probably look at HER2 low versus HER2 0. But now, do you really think that we should waste our time in doing biopsy or take away second line straight away? Destiny 03, approval in 65 countries. We have Tarini with us. He said thanks after the first case. So I don't know whether he has left or not. Dr. MV. Sorry?
Dr. TP Sahoo has logged out, sir.
Okay. Dr. MV, would you
So
really
yes,
like to biopsy at this stage?
So, well, if there is a possibility that it may completely become HER2 negative, and if it is HER2 negative, we do not know whether only that particular area is HER2 negative or all over the tumor is negative. So that's the question. So if it is completely negative, then there is a possibility that TDXD also may not act. So that is the argument for that.
Okay. Would you do a rebiopsy in this patient?
So yeah, in this particular patient, yes, I would do a rebiopsy. Yeah, because it is heavily pretreated, and this patient may be a frank
No.
triple negative.
When you gave TDM1 in this patient, would you
So
do
yeah,
a rebiopsy at that time? Because now you have TDXD available.
True. So we should have done a rebiopsy to look for the loss of receptor. But again, sir, if there is loss of HER2, I'm not sure whether the loss is homogeneous or it's a heterogeneous population. So now that we have TDXT, we are speaking of low HER2. But before the TDXT era, a HER2 positive disease now becoming HER2 negative. I don't know whether it is homogeneously HER2 negative or only that biopsied area is negative. So I would continue HER2, but I may give a good chemotherapy backbone for this patient.
Right. I think the last sentence, what you said, is the general consensus. Last 2 days, I have contacted at least 10 different people in India, and I have read articles. HER2 once positive, you may add the chemotherapy backbone, but do not take away anti-HER2 treatment in this particular patient. I think that is the bottom line, what we should look at it. Meenu ma'am, any last point on this patient, how you would have treated it differently?
So again, what I've already said. I mean, when today's date, I think everybody agrees we would have moved TDXD much higher and would have given that only. But on the other side, we all know that yes, there will be financial constraints, and at the end of the day, possibly we will treat the patient the same way. So not everybody, there are so many other things. Apart from science, there's also the other side of the story also. But
Right.
yes, if nothing is a constraint, then TDXT would be my go-to drug. And irrespective of HER2 positive and negative. Again, if the question is whether we will rebiopsy, I will say yes, I will still rebiopsy. Maybe that will be a learning for me. And but whether on that rebiopsy, if it becomes HER2 low, then whether I will stop targeted therapy or not give TDXT, I think I'll still go ahead and give TDXT, as was the question in the earlier this thing, unless it is a HER2 zero. And that also become a big question mark that whether I continue a targeted therapy or add chemotherapy. So we don't have so many answers at present. But yes, again, going back to the point you said, I think once HER2 positive, it might be premature to stop HER2 directed therapy in these cases, just on a single biopsy report.
Okay, perfect. I think, but we all have brought our point together. Just the last question to Dr. Warrior, sir. Sir, if tucatinib turns out to be cheaper than TDXT in coming years, and the HER2 climb also had 50% of the patients without CNS metastasis, would you use tucatinib upfront rather than TDXT?
I have used both, so I feel that we should be. I might use the deruxtecan first.
You might use deruxtecan. I think the point very well taken. Trastuzumab deruxtecan has turned out to be quite an effective drug, and with the curve separation in Destiny 03, I think that is stuck in our mind very much to use it. Wherever, as Meenu ma'am said, there is no constraints about the money. I think we should go ahead and try to give our patient the best. And with that, thank you so much, the experts in this panel. I think, it wouldn't have been better without you people. And again, thank you both the presenters, Dr. M.V. Chandrakanth and Dr. Akhil Kapoor, for such wonderful case discussion. Let's move on to the next set of experts. We have Dr. Joydeep Ghosh. Do we have Dr. Ullas Batra? Dr. Manasi Shah? Do we have Dr. Manasi Shah, Dr. Ullas Batra? Can Kavina
Hi, Dr.
Creations?
Vora. Yes,
And
yes,
Dr.
I'm here.
Manasi is here. Is Dr. Ullas there, Kavina Creations? Kavina Creations, I'm asking you a question.
7 minutes, sir.
Sorry?
Sir will join in 7 to 8 minutes.
Sir will join in 7 to 8 minutes. Dr. Amit Rauthan?
Yeah, hi. Hi, Amish.
Hi, Amit. We are missing your smiling face. You cannot switch off your video, please. Okay, great. And can I request Dr. Anbarasan Sekhar? I would again repeat Anbarasan Sekhar for your case, please.
Good evening. Good evening, sir. Thank you for the opportunity. We move on to this case discussion. She's sorry, my screen is visible.
Yes, it
Yes.
is visible.
But
Sir,
it's not.
if we can just request you to put it into presentation mode.
It is stuck with my system.
Sir, if you want, we can share the slides from our end, sir. You can say next whenever you want us to move to the next slide.
Yes, please share it.
Sophia, please share the screen.
So, Amish, I'll ask you a question till then.
Yes, please.
So this I couldn't understand it from this Dr. Sunil's presentation. But see, when we're talking of deruxtecan, we are talking of irinotecan, and we know there is a subgroup with that UGT1A1 deficiency who can have severe toxicity to irinotecan, and we worry about it when we give irinotecan. Occasional patients, at least we do worry. Would you worry about that when you do TDXT?
No, I would not, because I have thought about this many a times, and somebody also asked that can ILD because of the chemotherapy in trastuzumab deruxtecan, what we are looking at. I think the beauty about trastuzumab deruxtecan is internalization based on HER2 receptor, and then there is a bystander effect in the say 8, you say 1 to 8. 1 to 8 will include HER2 positive and HER2 negative, both bystander effects. So I think intranuclear concentration of chemotherapy is higher as compared to this, and these are going to be HER2 positive. Majority of them are going to be tumor cells, and that's the reason I'm not so worried. Amit, I don't know whether I answered your question or not.
No, my question came because we've seen a few patients with very severe neutropenia. It's very, at not that standard dose also. So it kind of comes down to the same way we used to see in irinotecan, those few patients who have that very severe toxicity. So that's the thought which was coming. I did see there was some analysis from the trial where they did mention that they were not concerned, but I would like to know that actually.
Right. I think, maybe somebody from AZ can take up Dr. Amit Rauthan's case and get back to him. And Dr. Sekhar, can you start?
Yes, sir. We move on with the presentation. Please move to the next slide. This is a 65-year-old female, known hypothyroidism, no other comorbidities, no family history of cancer. She was diagnosed as locally advanced CA breast cancer in 2016. Where that time she had left-sided breast lump, and biopsy was suggestive of ER/PR positive and HER2 3+ by HC. And initial evaluation, chest X-ray and ultrasound were normal. And patient told that tumor was too large at the time of surgery, and then she was started with chemotherapy. Next slide. And this patient from 2016 onwards, she is on chemotherapy for a long period of time. Initially, she was treated with paclitaxel and Herceptin. After 5 cycles, there were some new satellite lesions was there, and then multiple new onset lymph nodes was there. Then the treatment was changed to nab-paclitaxel along with carboplatin. Again, the treatment has been changed because of clinical progression. Herceptin and docetaxel has been used, and it has been changed to gem carbo.
Is Dr. Sekhar's screen frozen, or is I'm the only one who's seeing it as a frozen?
I guess Dr. Anbarasan is facing network issues, sir.
Okay, while he gets connected again, Dr. Joydeep, he mentioned one point that since 2016, this patient is on chemotherapy and ADCs. And
during the time she had
Dr. Sekhar, I would suggest that you join from your cell phone, since now your slides are presented.
Sorry, sir. Hello. Sorry for the disconnection. She has received 5th line of therapy with paclitaxel, cisplatin, and Herceptin. Move on to the next slide. And then she not have good response, so she shifted back to capecitabine and lapatinib. And during the time she was asked for surgery, but she was not willing for the surgery at that time. And then she again moved to letrozole and Herceptin. For 6 cycles she was on, and then she again had then changed to lapatinib and letrozole because she was not willing for IV therapy. And with lapatinib and letrozole, she had a local progression, and then capecitabine was added. In February 2019, after post 13 cycles of lapatinib and capecitabine and letrozole, she had progression at the local site only. That time, TDM1 was started for the patient. Almost 3 years she was on TDM1. In August 2022, she had a large ulcerative lesion in the breast, and she had a frank clinical progression, and surgery also not possible because the lesion is crossing the midline. During this time, she was started with chemotherapy with epirubicin and cyclophosphamide. During second cycle, she required dose reduction, continued with 80% of epirubicin and cyclophosphamide. Post 3 cycles, she had a good clinical response. And after completion of 6 cycles, she was put on palbociclib and fulvestrant and Herceptin as maintenance. After 2 cycles of palbociclib, she had a significant febrile neutropenia as well as thrombocytopenia, which required transfusion. Hence, palbociclib was withheld, and she was continued with trastuzumab and fulvestrant. After 4 cycles of trastuzumab and fulvestrant, she again had a disease progression in form of skin lesion, which is extending all over the chest wall, over the back region also. Next slide. So this is the summary of this patient who was diagnosed with breast cancer in 2016. She was on various multiple lines of chemotherapies from 2016. And February 2019, she was started with TDM1. Almost 3 years she was with TDM1. And August 22, her disease became inoperable during that time. And she was received first line of chemotherapy with eberupicin. And she was again registered with anthracycline and cyclophosphamide during that time. And post AC, she had good response. So we continued with Palbase and fulvestrant and herceptin. And she had neutropenia. Then we cut down palbociclib and then continued with fulvestrant and herceptin. And then again she having progression. Next slide. At present, her performance status is 2. Clinically, no organomegaly, respiratory monoid axons, and CT chest showing no features of ILD, no visceral disease progression at this time also. So I would like to ask, these are my questions. She is having only locally extensive disease in the form of chest wall disease, but there is no visceral progression. Even though she is HER2 positive, what we expect in HER2 positive patients to have more propensity for visceral metastasis, which is not her inner case actually. For almost 7 years, she is having only local disease, local site progression, and this time she is having extensive chest wall metastasis. And she has crossed multiple line of treatment also. With this, would you like to offer with TDXD or tucatinib with capecitabine or trastuzumab? Next slide.
Dr. Sekhar, yeah. So we understood, right? So can we move on to the panel now, Dr. Sekhar?
Yes, sir.
Okay, perfect. Dr. Joydeep, I was asking you, this patient is a triple positive breast cancer to begin with. Localized disease, unresectable, so you can put it into localized stroke metastatic disease. And I see 7th line, Dr. Sekhar introduced hormone. First 6 lines, it was chemo plus trastuzumab in a triple positive patients. Do you find it something different, something surprising than what we do?
Yeah, so I completely agree with what you said, sir. There are a couple of other things also which is I fail to understand. One is the role of carboplatin multiple times. Second is the role of taxane multiple times. I think if I'm not wrong, almost taxane was used 4 times back to back. So somebody who is having a progressive disease on taxane, we usually change to a non-taxane agent and continue the trastuzumab. So that is one thing. Another thing is that we do not have a baseline staging scan for this patient, if I'm not wrong.
So assuming that this patient has a chest wall nodules and armor stage cancer and QRAS, but there is no distant metastasis. Let's put it that way, Dr. Ghosh. That is what Dr. Sekhar wanted to say that, yeah.
So I may assume that throughout the whole course of the patient's journey, she never became resectable at any point of time.
Yes, that is what we are assuming, right?
Okay, okay. So yeah.
Sorry to interrupt. So in the beginning, she was operable. Before
Dr.
starting
Sekhar,
TDM1,
Dr. Sekhar, you can put this thing in the chat, because since you have lived this patient, you will have a lot of stories to tell. Let us discuss in the information what you have given so far. But you can keep putting in the chat box. I can understand that you are very passionate about this particular patient. Dr. Manasi, I would say is that the first 2 lines in this particular patient progress within 4 to 5 months or within less than 4 to 5 months of trastuzumab. Why not just give, AI plus CDK4/6 inhibitor? Patient is 65-year-old, postmenopausal, classical skin nodules, everything behaving like ER positive patients. Would you not now give up trastuzumab and use this thing? Because Cleopatra failed. He tried giving the control arm of Cleopatra. Within the 4 cycles, the patient progressed. So we cannot go to that line. Dr. Manasi.
So I think given that the patient was HER2 3+, what we can probably do is give hormonal therapy with anti-HER2 therapy rather than discontinuing anti-HER2 therapy completely. That is probably what I would feel comfortable with. And in terms of choice of CDK4/6 inhibitor, we do have data with using abemaciclib with the Monarch Her trial. So that might be my
Absolutely.
go-to CDK4/6 inhibitor if I'm assuming that we're not talking about cost at this point in time. So I think that probably would be my go-to option.
Right. Dr. Amit, the 12th line, there was palbociclib plus fulvestrant plus Herceptin in this particular patient. Okay. And what Dr. Manasi is saying, that we have the evidence of Monarch Her that we can give abemaciclib plus anti-HER2 early on. Where would you have put that particular in this particular patient?
So Monarch data we have seen, but I don't think we have any approval of adding anti-HER2
We
and
don't have.
CDK4/6.
We don't have.
So we would not do that in clinical practice. Monarch
Right,
is
okay.
definitely not an approved regime, and so at present, no CDK4/6 plus anti-HER2 till you get phase 3 trial data which says it gets approved. So I agree with
So
Mansi saying.
just hold on, Amit. I'll come back to you. Mansi, Amit is challenging your prescription. What are you going to do?
So, we have phase 2 data, and like we said that we will be treating patients individually. And so if you're seeing that the patient is not responding to chemotherapy, either we can do just hormone alone. So, AI with lapatinib and trastuzumab, if you want to do a dual anti-blockade, AI with pertuzumab, trastuzumab, we have data with that too. And so actually, if I have to say, I think in this patient, I would probably use an AI trastu-pertu if the patient has
AI
failed.
trastu-pertu, it was allowed only in the control or the maintenance of Cleopatra, Dr. Mansi. I tend to sort of agree with Dr. Amit, because in my clinical practice also, I do not try to deviate. Hospitals like Tata Hospital or Ullas Batra is an institute by himself. If he has joined, then it's a different thing. But if you do not have any label indication, it becomes very difficult when there is an unexpected side effect. So Amit, coming back to you, I give you two options to decide in this particular patient, because two different lines of chemo plus trastuzumab has failed. I would give you two options to pick from. ER strongly positive, only skin nodules behaving like ER/PR positive metastatic or locally advanced breast cancer. TDXD, because two different lines of chemo and the treatment is done, so you are within the label. Or say fulvestrant plus ribociclib.
So absolutely TDXT. I would say in an HER2 patient, even though you say triple positives, you still believe HER2 is a dominant mechanism. And I would really not
You
leave
show me one
anti-HER2.
clinical feature in this patient, Amit, in 13 different lines of treatment where it has behaved like HER2 positive.
Yeah. So having chest wall nodule going to cancer incurus also is seen in HER2 positive patients sometimes.
Correct.
And that's why we
Amish,
sometimes include radiation sometimes in some patients.
Can I come in?
Yes, so the institute has come already. Ullas sir,
Yeah.
welcome to you. Welcome to you.
So thank you and sorry for joining late. And I didn't really I have not really gone through the case. So, but I mean, initial presentations of HER2/neu, and I have had bad patients who have recurred only in the chest wall. So as Dr. Amit was saying, HER2/neu people failing only locally with subcutaneous nodules and cancer on cuirass or a locally ulcerative wound is something which is seen. And I agree with Amit.
So Ullas, let me stop you here. Ullas, just 1 minute. Out of 100 patients of cancer and cuirass without any metastasis in 13 different lines of treatment, biological behavior, how many HER2 positive and how many ER positive would you qualify?
No, Amit, Dr. Amish, mere khayal se, I think we are missing the tree for the woods here. The point is, I will say, if anybody is HER2/neu positive, at HER2/neu directed therapy should take preference over the other ones. I did hear you asking about when will you put this or not. So maybe after third, fourth cycle, you can put whatever you want, some hormone and all, just to increase the PFS. But if you have a drug like TDXG, which is supposed to work, I think it should be given and it should get preference over something else.
Okay, perfect. Your point well taken, Dr. Joydeep Ghosh. Would you agree with Dr. Amit and Dr. Ullas that this particular patient, they will not look at AI or fulvestrant plus CDK4/6 early on, maybe later on, TDXT first as soon as you get the labeled indication?
Yeah, I would also go with TDXT. So only concern is that, are we sure about the histopathology? Because HER2 blockade was given at every time point, and we did not have a favorable response at any time point. That is very unusual in a HER2 positive cancer. So a rebiopsy would ideally be considered at the first progression of
So,
this.
I sort of tend to agree with you, Dr. Joydeep Ghosh. 13 different lines of treatment. Although, yes, we are in AZ webinar. We are supposed to say TDXT. But this particular patient, if my DM degree is hanging on that, it is actually not behaving like HER2 directed clinical presentation. I would definitely use TDXD in this patient, but I would also definitely use fulvestrant plus CDK4/6 inhibitor early on, going by the clinical presentation. But that's a discussion sort of, we can keep it.
May I just interrupt here? I'm sorry.
Yes, Dr.
So I think,
Mansi.
when you initially asked the question, I thought you were asking the question in the given time frame that the patient had progressed. So I think in that year we didn't have TDXT. Secondly, I think this patient has failed trastuzumab, but if you look at lapatinib and if you look at TDM1, the patient has responded to both those anti-HER2 agents. So I think rather than saying that the patient has not responded to any anti-HER2 therapy, probably patient has trastuzumab resistance rather than a non-HER2 biology is what I would say.
Okay, right.
Lapatinib for Amish is
we
not
come to
an
that.
anti-HER2 new agent, Dr. Manasi, actually, Lapatinib is for big people like Amish. No, they don't consider all this small time Lapatinib and all. Forget about that. Yes, Dr. Amish.
Ullas,
Saying something.
before we go on to the next case, there was a question before you joined in, we asked, and Dr. Amit Rauthan and myself sort of versus Dr. Mansi. So now,
The lady is always right. Before listening to the question.
Monarch Her allowed us to give abemaciclib with anti-HER2, although we do not have any approval. So Dr. Mansi said that in this particular patient in a triple positive, she would be inclined to use abema plus anti-HER2. Amit and myself, we believe that unless until we have a labeled indication or approval, we should not use. Ullas, what would you say?
So I'll agree with both of you. It depends upon the volume of the disease. It depends upon the line of the treatment. It depends upon the tolerability of the patient. It also depends upon where you want to place it. I won't reject it outright, but I mean, it won't be my go-to option to first line. That's what I would say.
Okay, right. Dr. Joydeep, the last question, which basically Dr. Sekhar asked, and then we can move on to the next and the last case presentation for today. After the 13 lines of treatment, 12 lines of treatment, now we are sitting on the 13th line, still the patient has not progressed. Would you use TDXT or would you use tucatinib in this particular patient now if the money is not an issue?
I would go with TDXT.
You would go with TDXT. Dr. Mansi?
We have that drug available, so I think we just go with what is available.
So both tucatinib, assuming if it is available, then?
I mean, I think, we're talking about sequencing here because eventually the patient is going to require both. As discussed earlier, we have evidence of tucatinib in later lines, and both drugs work equally well systemically and intracranially. I would use the trastuzumab deruxtecan and then use tucatinib second after that.
So this is the 12th line. We already have third line, but I agree with you. We have the sequence of tucatinib in the later lines. Ullas, if the generic tucatinib is cheaper than TDXT, what would you use? Ullas, you cannot switch off your video. Sorry.
I was actually trying to let you to read about the case, 13 lines of treatment, and I was thinking, kya reh gaya hoga abhi? I haven't really heard the case, but I mean, going by what the consensus statement, I think, and then we discussed in the last chapter also, first of all, TDX is available. Tucatinib can be used later. I think TDXG goes first. I mean, let it be a clear statement.
Amit, generic tucatinib is 1/4 the price of TDXT. Would you still go for TDXT first, followed by tucatinib?
See, if the patient can afford it, the PFS of TDXT is much, much higher than PFS of tucatinib. So easy choice to TDXT if the patient can afford it. If they can't, there's no choice.
You raised a very, very valid point, and I don't agree with that on that, Amit, very much. But Ullas, If the control arm and the experimental arm, the hazard ratio is 0.65 in both the trials, assuming, but the numerical values of PFS is higher, how would you read both the papers? Very quickly on for my learning, and we can move on. Sorry.
So you are asking to discuss about Herclimb and TD and
No, I'm asking a simple basic statistical question. That's all.
No. I think you should not do a cross-trial comparison. I think you should look at the patient. You should look at the denominator also. I mean, let's just look at the denominator. No, I mean, somebody's comparing against if the denominator then becomes a TDXG and then the HR is 0.65 versus if it is a Lab-Zaloda or a TPC, it's different. So look at the denominator. I mean, that's for me is very, very important. Let's not get fooled by HR of 0.65.
Okay, so just perfect. One point here, sir. Amish, sir.
Yes.
If the disease, if at a particular situation, the disease PFS is normally very small, in that situation, even if there is a 2 to 3 month of benefit, the hazard ratio will come as 0.6. So that's the problem with these later on.
Ulla, you have to learn to answer from Ullas. He also knows the answer, but he gave a politically correct answer. That's why I asked Ullas. But Dr. Ghosh, if you see Destiny 03, the control arm TDM1 was 6.8 months PFS. Okay. And Emilia trial, the experimental arm of TDM1 was 10 months. So probably somewhere we have to look at, but even that still, I think TDXD data in 01, 02, 03 so far, definitely, out benefits, and we should offer our patient as and when we have this thing. With that, let's come to the last paper.
Point.
Yes, Amit, and we can have
Point.
Jyothis Jose. Yes, Amit.
So last point.
One point to last
the
point.
hazard is 0.2 is nowhere near 0.65, one of that TDXD. Second, if you bring up the question of HER2 climb as a design, a doublet versus triplet I would definitely not agree with that. I would say then the triplet should have been there, at least a lap should have been there in the comparator, and we may have got an even lesser hazard in tucatinib trials.
So Amit, if you put the PFS of Emilia for TDM1 in the Destiny 03, your hazard ratio from 0.3 will become 0.6. I have calculated that, but let's not go into that discussion. TDXD is a very, very good drug. And now over to
only one point to add, sir. Amish, sir, one request.
Yeah. Last point, and then the last by Dr. Jose.
Yes, sir. So the patient received almost 3 years of TDM1, sir, in this patient. So after 3 years and 6 months of TDM1, TDS is still a preferable option.
After 3 years, Destiny 01 had, I think, almost 40% of the patient who had received TDM1 earlier on. Although we do not have the subset, Amit may know whether they were 6 months, 1 year, or 2 years. It is that patient were on TDM1 and they were progressed. So we have the data that after TDM1, the TDXD still works. And that was again the response rate in Destiny 01 of 60%, which was amazing, I think. So we can definitely sequence irrespective whether 1 year, 2 year, or 3 year. That is what the data says. Thank you, Dr. Sekhar. Excellent. And let's move on to the last case for today by Dr. Jose, MVR Cancer Center, Calicut.
Amish, can I just come in once? I just, in the meantime, when you were teaching us, I just looked at the case. I think I missed the first point, so sorry for that, but I would definitely want to do a rebiopsy somewhere down the line in this. And my question now to you, and just just to put a finger in this thing, is let's say you do a rebiopsy and the HER2 comes as 0. Will you still ever use TDXD in this patient?
The first two cases we discussed that, Ullas.
Okay.
And we said that HER2 3+.
In this patient, which is biologically as per you not behaving.
First two cases, both were HER2 3+ became HER2 2+. So we discussed that even if it becomes HER2 0, we may add chemotherapy backbone, but we would not sacrifice anti-HER2 treatment in this particular patient. Okay. That is what our consensus was. Okay. Over to Dr. Jose, please.
Thank you for the opportunity, sir. This is our experience with trastuzumab deruxtecan in our MVR Cancer Center, Calicut. I think the slides are not moving.
Go to the next slide.
The slides are not moving, sir.
Do we have the backup for Dr. Joseph's slides?
Yes, sir. We're just playing those slides.
So you share, and Dr. Jose, you can keep saying next slide, next slide.
Okay, sir.
And Dr. Jose was sounding very confident till Ullas Batra was, smiling, and now he became little conscious. Dr. Jose, you don't have to become conscious. Just, share your discussion.
Okay. Next slide, please. Hello.
Dr. Jose, you'll have to
Okay.
say previous slide.
Okay. 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 Our patient was a 61-year-old female. She's from Kannur, Kerala, diagnosed with a stage 2
Previous
breast
slide
cancer.
is not visible, Dr. Jose.
No, Dr. Jose, nahi. Kavina will put the previous slide. Kavina, can you put the previous slide, please? Yes. And now Dr. Jose can start.
Okay. So our patient is a 61-year-old female from Kannur, Kerala. She's diagnosed with stage pathologically T2 M0 breast cancer in 2019 November. Subsequently, patient received 4 cycles of adriamycin cyclophosphamide followed by taxane and trastuzumab, and received 17 cycles of adjuvant trastuzumab till January 2021. Subsequently, with a DFS of nearly 13 months, patient relapsed with a chest wall recurrence and lung nodules, and as well as a lesion in the right breast, and rebiopsy, which is ER/PR negative and HER2 positive. Next slides, please. Okay, next slide, please. So, and in the first line, patient received trastuzumab with pertuzumab for about 6 cycles, and subsequently, patient was a progression in the sternal deposits as well as in the right breast lesions. Next slide, please. So patient was received the second line at TDM1 for about 4 cycles. At that time, the patient came to our hospitals with a clinical evidence of disease progression in the sternal swelling as well as the right breast lesions. Subsequently, we have discussed the option of TDXT, and the patient was started on trastuzumab deruxtecan. Next slide, please. So that time the patient weight was around 50 kg. She received a 270 mg of trastuzumab deruxtecan. And as you can see, there was a response in the right breast wall, breast swelling as well as the sternal lesions. Next slide, please. Okay, this was a CT report which showing almost a favorable response in the breast lesion as well as the sternal deposits, and stable disease in the lung nodules and the bone lesions. Next, please. Okay, in view of logistic reasons, patients couldn't afford TDXT further. So we have started the patients of lapatinib and capecitabine, and the patient received for about 3 to 4 months. In July 2023, patient had a disease progression in the disease progression. Subsequently, we have discussed the option of TDXT again, and the patient was again restarted on TDXT. That the weight of the patient was around 37 kg, and patient received 200 mg deruxtecan. Next slide, please. So this is the follow-up imaging again. So at the December 2023, a patient had some response in the breast lesion and almost some stable or minimal response in the sternal lesions. Next slide, please. So this is a side effect which is we observed as a grade 3 neutropenia. So we waited till the patient recovered to grade 2 neutropenia and restarted the patient on same dose. Next slide. So with this, I'm ending my presentations. So this are my I would like to know about what is the best next line and how do you manage adverse events and what is the guidance on rechallenging.
Okay, perfect. Thank you, Dr. Jose. Let's start with Dr. Manasi. Dr. Manasi.
Amish, can I just for my clarity, the first line treatment was pertuzumab and trastuzumab only, no chemotherapy.
Yes, sir. Actually,
He was given paclitaxel.
No.
He
Just
was
can,
given chemotherapy, what I felt, chemo plus
just can
Trastuzumab
you show the
plus Pertuzumab.
slides, please, Kavina? The first line, it was written in Pertuzumab and Trastuzumab only. No dosing, no this thing. Can we have the
Yeah.
slide?
Even I
Dr.
was.
Jose, you had treated this patient. What did you give?
So this patient was received from the till TDM1 patient was treated from a separate center, sir.
That's
so
okay.
that time like retrospectively looked the details, they only received Trastuzumab and Pertuzumab, no taxane, sir.
No taxanes. Okay, perfect. Dr. Manasi, stage
Yes.
2 to begin with, treated till January 2021, patient completed 1 year of Trastuzumab, and 13 months later, this patient had metastatic disease and some doctor re-challenged with Trastuzumab and added Pertuzumab. Would you agree with this line of treatment? Ullas is already nodding. He's saying,
I
yes,
think
I
more than
agree.
12 months, you can re-challenge with Trastuzumab. So you can go with Trastuzumab, Pertuzumab, and a taxane, like add chemotherapy.
Okay, if you have TDM1 and TDXD both available today, and patient progresses on Trastuzumab 1 year in adjuvant setting and PFS of 13 months, would you go for TDM1? Would you go for TDXD, or would you add Pertuzumab the way it was done here?
I mean, I think I would still go with the way it was done.
Okay, Amit, you agree?
Absolutely. So this fits the Cleopatra. So this is first line still. It's post 12 months. So
No,
classical.
but 1 minute. Cleopatra allowed us to give T plus P without chemotherapy?
No, first line.
That's why Ullas clarified upfront that what I asked is you add Pertuzumab, but you do not give chemotherapy.
So we wouldn't do that, you know. It's just that
fine.
for
So
some
you
reason
would
that must have
this is a
happened.
classical case of Cleopatra. You would give THP followed by HP maintenance and nowadays the FASCO, which is there. Okay, fine. Dr. Ghosh, this particular patient, there was a logistic reason, and that's why after TDXD, they had, let's come to TDXD because, we are discussing TDXD today. Instead of that, if the patient has grade 1 pneumonitis, and you have two scenarios, if the patient pneumonitis subsided within 28 days or did not subside within 28 days, what would you do? Because that was one of the questions which Dr. Jose wanted to ask, that how would you treat the side effects?
Yeah. So if it's pneumonitis, I'm really worried about reintroduction of TDXD in this situation, especially if it has not resolved after 28 days. And if it has resolved, then we can re-challenge. Of course, I need to check the dose modification guidelines. Probably we have to come down to 1 dose level low. But yes, in that case, I'm okay. But if it persists, then I'll definitely not give.
Amit, you must be the highest number of users of TDXD in India. How would you modify grade? See, if I understand correctly, let's not waste our time in grade 2 pneumonitis, because grade 2 pneumonitis, we are not supposed to give TDXD again. Is that right?
Yes. So the guidelines are very clear. If you're on patient on TDXD, especially breast cancer people, they do a CT scan every 2 to 3 months because they want to catch it before the patient is symptomatic. The patient is symptomatic, it is already grade 2, you can't give further TDXD. So we want to catch them in grade 1. Grade 1 means they're not symptomatic, you see lung changes. The only difference in grade 1 is here we are allowed to start steroids at 0.5 mg per kg, give it 4 weeks. If they settle down, you are allowed to again restart and continue at the same dose. If they take longer than 4 weeks, you have to go 1 dose level lower.
Okay, so that means 5.6 to 4.4 and 4.4 to 3.2. Is that what you are looking at, right?
Right.
Okay, perfect. So how many, Amit?
Amish, can I just ask you one question? Because the vast majority of these patients would have received multiple lines of treatment, and the ILD is a common thing with other agents as well. So, if it is, how will you identify whether it is because of the deruxtecan or because the radiologically there is not much progression, but the patient can be symptomatic. In
Right.
that
Amit, would you like to take that?
So in breast, it's not a problem, but in lung, it's definitely a problem, and Ullas will answer this.
No, I can answer for both breast and lung actually, because we did take part in Destiny Breast and Destiny Lung both. So, sir, I mean, in the trials, it's very simple. We do a 6-minute walk test to start with. Very important, very feasible is to make them walk for 6 minutes, look at any desaturation or any tachycardia, and then do a PFT with DLCO. That's very, very important, number one. We do an HRCT, or we ask our nuclear medicine people that while they are doing a PET CT scan to take an HRCT cuts also. And as Dr. Amit Rauthan rightly said, every 2 cycles, you have to do a CT scan with an HRCT cuts. So, sir, I mean, if there was nothing to begin and start with, and it has come on TDXD, it is definitely because of TDXD. Major problem comes in lungs when you can confuse with lymphangitis. In that case, you have to do a proper workup. You do a bronchoscopy, you do lavage, you do send PCP, and you do send galactoman, and you do send hundreds of issues and try to get a biopsy. Easier thing in clinical practice is to stop. In the trial,
Ullas, in the clinical practice and in real world experience, Ullas, can you tell your experience of TDXD and pneumonitis, whether it is breast or lung, doesn't matter?
Reasonably good. Again, the patient selection has to be very, very good. I keep on telling, do a 6-minute walk test. I mean, that is the most, I mean, I have stopped people from getting any of those therapies. The 6-minute walk test is not good. If you, in people who are smokers, more lines and all, it is more likely to come. It's reasonably okay. I mean, to me, major problem with TDXD has not been ILD or pneumonitis. It has actually been nausea, vomiting. Initially, when the drug came, and now we are giving steroids after that. The second problem was fatigue, weight loss, fatigue, and neutropenias are reasonably okay. I mean, ILD is not really a major issue till now, touch wood.
Okay, perfect. Great. If Ullas says it's not an issue, then, we take it as a gospel truth. Dr. Manasi, this patient had PFS of 13 months. If this patient would have had PFS of 6 months, would you give the same Cleopatra or would you go for TDXD?
So if the patient has a PFS of 6 months, then I think we would not use the trastuzumab pertuzumab regimen. So we don't have first-line TDXD approval as of right now.
Mansi, you were planning to use Monarch Her in your patient, and now you are looking at first-line approval.
I'm just clarifying it because you probably would not, since there is no approval, but I would use it. I would use it first line.
You would use it first line. Amit, if you see Destiny 03 inclusion criteria, it allowed me to use TDXD in adjuvant, neoadjuvant setting if they progress less than or within 6 months of that use. Would you take that and use TDXD in this patient if the PFS is, say, 5 months and 28 days?
Yeah, it makes sense. No? It really makes sense. That's how the trial did it and did have those group of patients. And I think they will, I would use it. I would say yes.
So can I be slightly different, Amish, and saying ki, see, you can always use TD. See, again, it depends upon the volume of disease and the sites of disease and the patient's performance status. If you don't use pertuzumab right now, when will you use pertuzumab?
Why do you love pertuzumab so much?
See, in HER2 new, you don't want to give up on an anti-HER2 line of therapy like that. Correct. So
Ullas' point is that less than 6 months, there is a trastuzumab inherent resistance, which is already clinically
you are adding
documented.
pertuzumab.
You are adding pertuzumab thinking that it will reverse. You're very optimistic, I must say, in this particular patient. I would use TDXD in this patient because we have the drug available. We have a superior drug available. But yes, Dr. Ghosh, like Ullas said, would you add pertuzumab or would you switch over to TDXD if the PFS is less than 6 months?
So I think we can go with the trial inclusion criteria and use TDXD in this situation. Because practically it's a trastuzumab resistant disease.
Trastuzumab resistant disease.
Warrior was asking something.
We would use TDXD.
Ullas,
Sorry?
I feel pertuzumab will not be active in later lines. So wherever possible, try to expose patients to in the upfront scenario. Yeah, of course, TDX1 is coming upfront, but still, I feel that pertuzumab should be used either in the upfront or at least immediately after TDX1.
Our moderator seems to have disappeared. Like the effect of trastuzumab.
मॉडरेटर को बार बार निकाल दिया जाता है ये बोल के बस हो गया. And we have crossed. Anybody have any comment? Otherwise, we close this panel.
I wanted to ask people who have used TDXG. See, we are using clinical scenarios and this thing. How has the experience been?
So,
So we've used it in. I'm sorry.
Go
Yes,
ahead.
Dr. Mansi, please go ahead.
Go ahead.
No, so we've been a part of the Destiny 09 trial where it's been used first line, and it's been excellent. Patients are definitely doing better. I'm not sure if I'm allowed to say this, but patients are definitely doing better on the TDXD arm than the THP arm. And in terms of side effects, like you said, nausea, vomiting, fatigue, alopecia initially, and then somehow it just plateaus off. I've had one patient where they've had skin reactions, so which has been very unusual, but that's the only unusual side effect, and one patient with pneumonitis. So great.
I know of your person with pneumonitis, Dr. Mansi, because we keep on getting the same emails. My co-investigator's name also is Mansi. So, we get ILD ke baare mein bata do. So I definitely knew you had one, and we didn't have any.
Okay.
Okay. Yes, Dr. Joydeep.
So Amish, please tell us about what is next option for her.
This particular patient, fourth one.
Yeah. So fourth case, the one from MBR Cancer Center.
So the TDXD is responding. So we will continue TDXD till it responds. Then you have many other options because the overall survival in Destiny 03 also is very good because you have a second line, fourth line, fifth line treatment in HER2 positive. HER2 positive is like positive of lung cancer. Then you have multiple lines of treatment. You can use LabCat, you can use tucatinib-based treatment, you can use chemotherapy and re-challenge with trastuzumab. You have multiple options in this particular patient.
So Amish, can I ask a question? Quick.
Yes, Amit, but your video is off or I'm not able to see you.
No, we can't see you. We are seeing each other.
Okay, I can see you now.
So
Yes,
my question is, so this is something that we have had on challenges. A few patients who have got TDXT long-term, and then after long-term TDXT have progressed, and then we did a biopsy and the HER2 became 1+. Now what do? Do you offer tucatinib, capecitabine, trastuzumab, or do you say now it's 1+, we can't do it? And this is real life patient after 1.5 years of TDXT has started progressing, and we did a rebiopsy and it's HER2 1+.
So Amit, when you say, Amit, when you say this, I would like to answer you in questions like, you have to look at the three aspects in HER2. First is a protein expressions on immunohistochemistry. Second is a gene amplification on FISH. And the third is HER2 clone if on RNA. Okay, so if you can prove that there is a HER2 clone on RNA which is lost, that means there is definitely HER2 is not responsible for clinical progression. But in the first two scenario, there is no guideline in the world which says that you do not use anti-HER2. So I would use tucatinib in this patient, even it is 1+, not just because it is now HER2 low, because that doesn't happen generally unless until you prove at RNA level.
So probably we would say that in the old era, but now with TDXT, the things may change because the way TDXT requires just the most minimum HER2 in to get in, and after that, the clone of cells may change completely. So there's a thought that it may not be the same in TDXT era now. And I think we learn about this more as we get more and more experience of failing patients.
You are absolutely right, Amit. Post TDXT is something where I would not look at down-regulating of HER2 or post-pertuzumab or post-trastuzumab or post-TDM1 because we do not have enough data to say that HER2 clone is not responsible for clinical progression. Yes, if it is 0 and if ERPR is negative, I would definitely add chemotherapy backbone and not just give ADCs. So with that, let's close this discussion because Ullas next point would be कि wife पीछे बोल रही है खाना खाने बुला रही है उससे पहले I think
उसने मना कर दिया है, बोला आज खाना नहीं मिलेगा, आज
over to AstraZeneca.
Thank you
so
you
much
all.
all the experts.
Thank you.
Thank you, sir. Thank you so much. Thanks to all the experts as well. Thank you.
Thank you.
So with your permission, I may end the meeting.
Yes, please.